Hi, my name is Anat Galor, and I am a staff physician at the Miami VA and a professor of ophthalmology at Bascom Palmer. And I am so excited to be here today to talk to you a little bit about allergic conjunctivitis. And I always think it's best to start with a case. This is one of my patients. He's 58, and he tells me he has sore, itchy eyes. And he also tells me that his tears burn his skin. Fortunately, his vision is good, but when you start the exam, you can already see that something seems not right with his periocular skin. It's thickened, and when I look at his palpebral conjunctiva, what I'm seeing are papillae, and I see a little bit in the right eye and more in the left eye, along with some discharge. And so, of course, I diagnose him with a chronic papillary conjunctivitis, which has a differential. But what he tells me is that he's had skin rashes like this on and off his whole life. And that narrows down my differential to likely something allergic. But the question is what kind of allergy? And the punchline of today's talk is that allergic conjunctivitis is not all the same. There are different types. And so the goal of today's talk is going to be to review these ocular allergy subtypes and talk about all the things that make them different from each other and also what is similar across the different subtypes. And I think a good place to start is with SAC and PAC. That's short for seasonal allergic conjunctivitis and perennial allergic conjunctivitis. And that's because these two are the ones that are most common. So most cases of conjunctivitis that you see will likely be SAC and PAC. And so let's start with symptoms and signs. What are you looking for? If you see itching, bulbar hyperemia, tearing, oftentimes the periocular skin looks okay, but sometimes it has mild edema. Those are all things that are suspicious for allergy. And then it's important to talk to the patient because there are various host-related factors that increase the risk of having SAC and PAC, and that's mostly having any type of atopic disease elsewhere, but also a family history of atopy, and likely genetics underlies susceptibility. But then there are other risk factors. What are people being exposed to? And also age of when everything started, because again, in SAC especially, it generally starts in childhood. But the most important part of the exam is the slit lamp examination, where we look at the palpebral conjunctiva, and not just the inferior palpebral conjunctiva, also the superior one. The punchline is no exam complete without flipping the eyelids. And because it's so important, I think we need to spend a little bit of time on what we're looking for. So it's always important to know what is normal. This is what a normal palpebral conjunctiva should look like. You see the blood vessels. There are not that many of them. They're mostly linear, and between the blood vessels, it's pink. That's normal. Here we start seeing abnormalities, and one of the abnormalities is anterior blepharitis in the form of debris on the eyelashes, but let's focus on the morphology of the palpebral conjunctiva. What we're seeing here are just more blood vessels, but we can still see them, and there's still pink between them, and this is what we call palpebral hyperemia. It's not specific, it just means there are more blood vessels, and that's why everything looks redder than what we consider normal. But here's where the pathology starts. Here you can't see the blood vessels, and instead you see these small red dots, and they're obstructing the view of the vessels. And sometimes those red dots are medium in size, and sometimes they're large in size, and that's what we call papillae. And the punchline is you can't tell if someone has papillae without looking at the lids, because look at the bulbar conjunctiva, it looks pretty good, but when we pull down, we see changes more so in the right eye than the left. Now this looks a little different. Here we're seeing more translucence bumps, and those bumps are called follicles. Here we see that there are bumps, but on top of that papillae, and you can have a mixed follicular papillary reaction. And here's another example of these round bumps. They're opalescent, and they're really collections of lymphocytes. So when you see a follicle, you know that it's a collection of lymphocytes. Here are those small red bumps again. So that is papillae, and that's really a central vascular core. And then sometimes it's just a flat vascular core, so you just see the dots, but sometimes the tissue around it is elevated. That's when we start calling them medium or large size papillae. All right, well, this is another example of a conjunctivitis because you can't see the vessels. Whenever you can't see vessels, it's probably a conjunctivitis. Not always, but often. But this one looks different. Here, it's more of a pink, white lesion or process that's covering the vessels, and that is characteristic for scarring or fibrosis. And whenever you have a connection between the palpebral conjunctiva and the bulbar conjunctiva, that's called a symblepharon. So this is chronic cicatricial conjunctivitis, or CCC for short. Here's another example. We can't see the vessels, and that is because there is a membrane covering them. This is another example. And just for the terminology, a pseudomembrane means you can peel it away without bleeding. A membrane, when you peel it, it bleeds, but oftentimes it's a combination of the two. And the idea is it's so important to really spend time looking at the palpebral conjunctiva because each has its own differential. And when I see these small papillae, like I saw in a 55-year-old patient of mine who is a dog groomer, and she comes in with irritation only in her right eye for 3 months, no symptoms in her left eye, I start forming a diagnosis based on what I see. She has a mild papillary conjunctivitis, small papilla, right eye more so than left. So the first thing I think about is this acute or chronic? And our definition, anything greater than 6 weeks is chronic. So she is in the chronic phase of conjunctivitis. And then, as we mentioned before, there are many different things that can cause a chronic papillary conjunctivitis. It's not a specific diagnosis, so exposure, an anatomical abnormality. But in her, because of her symptoms and her occupation, I'm worried about sac or pack. I'm specifically saying, could she be sensitive to the dog grooming chemicals? And maybe she's rubbing her eye after treating the dogs. And so when I think about a specific allergic conjunctivitis, the first thing is to try to understand what's causing it so I can figure out how to treat it. And when it comes to sac and pack, these are type 1 IgE mediated diseases. SAC is generally episodic. It happens at a predictable time of year, but different climates have different courses of when the symptoms present. And the common offenders are things like pollen in trees. And I would say in Miami, in these subtropical climates, we have a much longer allergen season. So people seem to have SAC almost year round. But how does this happen? What's the pathophysiology? So it starts with an introduction. Something like pollen meets a dendritic cell and is captured by the dendritic cell, an antigen on the pollen. And the dendritic cells then present the allergen to naive T cells in regional lymph nodes. And that causes the T cells to differentiate into Th2 cells that produce specific cytokines that cause B cells to undergo class switch, and they become IgE producing plasma cells, like the one you see here. And in our case, this plasma cell is now producing an IgE that can identify pollen antigens. And what ends up happening is the IgE that's made by the mast cells can bind, by the plasma cells can bind to a mast cell, and this now causes the mast cell to make even more receptors for IgE. Now, this is what we call sensitized. The mast cell is sensitized, but the patient at this point doesn't feel anything. What happens is when there's a not so nice reunion, another interaction with pollen, what happens is the pollen antigen causes the two IgEs that are sitting on the IgE receptors to cross-link, and that causes a reaction where the mast cell spits out lots of things, including histamine, and starts the process, and now the patient feels something. But it's more than just histamine. The mast cell can spit out other things like prostaglandins and leukotrienes that cause lots of things to happen, vasodilation, mucus production. And then there's a late phase response where more cells are recruited to the area. So really it becomes a cycle of inflammation. And our job is to break the cycle. And so step one is to identify the trigger and avoid it. And I have had patients whose trigger was cockroaches. Sometimes people already know what they're allergic to, but if they don't and it's severe enough, I do recommend allergy testing And then I want them to avoid the allergens. Or what are the ways to do that? One way is to wash your hands and not touch your hand to your eye in the setting of allergic conjunctivitis. But the other environmental manipulations depend on the allergen. In the case of my patient with a cockroach allergy, tenting his house made his symptoms so much better. Medically, though, short term, if the inflammation is severe, I use corticosteroids. But longer term, I like antihistamine mast cell stabilizer combinations. And I also use lubricating drops. And some of these antihistamine mast cell stabilizers are available over the counter, the ones in blue, and others require a prescription. Having said that, there are other options available, like mast cell stabilizers alone. We'll talk about them later. Generally, for sac and pack, I like combinations, but the mast cell stabilizers do require a prescription. There are lots of studies in sac and pack on the different treatment types. And one study looked at ketotifen and olopatadine, which are both over-the-counter medications, compared to lubricating drops. And they looked both at clinical scores, so itchy, tearing, and also findings on impression cytology. And interestingly, the clinical scores improved in all groups, which means even lubricating drops help, but they were improved most in ketotifen and olopatadine, and the inflammatory markers seen on impression cytology went down more with the ketotifen and olopatadine. And this is an example of the study findings looking just at itching and tearing, showing how the treatment groups with ketotifen and olopatadine improved more both at 15 days and 30 days compared to the lubricating eye drops. But there are some studies that suggest that olopatadine may be better. One study design looked at a drop of olopatadine in the left eye, and in the other group, it was reversed. And 12 hours after installation, the subjects were challenged to something called a CAC. And itching was then subjectively graded after this challenge. So what is the challenge? What is a CAC? This is something that's really commonly used in many allergy studies. The first thing is you choose the allergen that triggers a response in the patient. Sometimes the patients know, but it's oftentimes determined with a skin test. And then you start testing the effect of that allergen in a patient's eyes. You start with the lowest concentration and you wait to see if there's a response. And if there's no response, you just keep on upping the dose till you get the response you want. And then you know that you get the response. So now you can see how different medications you use modulate the response. And this is the data of itching after a CAC challenge, which whatever allergen and at whatever level the patient responds to, with olopatadine and ketotifen. And you can see here there was less itching at each time point with olopatadine. And olopatadine was also more frequently preferred based on tolerability in that study. But as I said, there are lots of studies, and another one compared to other agents. One was olopatadine and epinastine in each eye. One was only olopatadine versus placebo, and one was epinastine versus placebo. And again, people got the drop, and then 5 minutes later, the CAC challenge, and again, itching assessed after the challenge, along with redness and chemosis. And here again, you can see the curves both for itching and for redness. And again, olopatadine was the winner in this study. And the same results happened with olopatadine compared to another antihistamine mast cell combo. And so many of the studies, not all of them, but in many of them, olopatadine did the best. And so the question then is higher concentration better? Do you get better results? And olopatadine is available in different concentrations, 0.77, 0.2, and 0.1. And so one study compared the different concentrations. And what they found is that, yes, you got more itch relief after 24 hours with the higher concentration of olopatadine. And you can see here the response between the 0.77% and the 0.2%. Both the 0.77% and the 0.2% are recommended to be dosed once daily. The 0.1% is recommended to be dosed twice daily. So in this case, yes, higher concentration, better results. But that is not always the case because there was another study that looked at ketotifen, another antihistamine mast cell combination, and looking at the 0.025 versus the 0.05% concentration. And in this case, while both were highly effective, the symptoms and signs were better reduced by the lower dose of ketotifen, and it was better tolerated. Okay, so in this case, less is better. Some studies have looked at combo treatment, so a combination mast cell stabilizer versus an antihistamine, and the combination did better. And it's the combinations that are available over the counter. So really in practice, clinically, I always recommend a combination. Studies have looked at topical therapy versus oral therapy for allergic conjunctivitis, and topical therapy wins. So one study looked at loratadine, which is an oral medication, versus olopatadine versus placebo. And it was complex because in one group, they got both the loratadine with the olopatadine, and in one, it was a placebo tablet versus the olopatadine eye drop. And in all the groups, they got the CAC antigen challenge. And there were two different ways that they tested. One, they gave the therapy an hour before the challenge, and in another one, it was 8 hours before the challenge. And in both cases, the Patanol with the placebo pill did better than the oral medication with a placebo drop, suggesting that for topical issues, for allergic conjunctivitis, a topical solution is better than an oral one. And the same question was asked with a nasal spray. And again, the results were the topical beats both the oral and the nasal spray. So if your patient has a topical allergic conjunctivitis, a topical eye drop is the best. Now, it is important to recognize that there are other combinations out there that are used beyond antihistamine mast cell stabilizers, and those are vasoconstrictors. Patients like the vasoconstrictors because they get the red out, but there are downsides with the vasoconstrictors, and you can get tachyphylaxis. So we don't like to recommend it in the long term. And studies have looked at comparisons between antihistamines with vasoconstrictors versus antihistamines with mast cell stabilizers. And the punchline is that a lot of these methodologies are the same. They usually give the medication before the CAC and then assess outcomes after the CAC. And in this case, you can see that it was the antihistamine vasoconstrictor that was the overall winner. But when you ask patients what they preferred, it was split between the two, and both were better than placebo. But the reality is that we very rarely recommend these. Short term, no problem, but vasoconstrictors have side effects in the long term, mostly that you get this rebound redness, and patients they require it, and they don't like to stop it because the redness comes back, and that is just sets up a cycle that we don't love as clinicians. And so in general, even though those options are out there, the combination antihistamine mast cell stabilizer is the one that I always recommend. But it's important not to forget about lubricating drops. And there's so many of them. And patients often ask, like, how do I find the right one? And so just a quick primer is that they have different active ingredients. And so that could be cellulose or polyethylene glycol. So there are different ones. And each of the different ingredients have different brand names. So the ones that are mostly the cellulose derivatives, those are the Refresh brands and the Genteel. The ones that are the propylene glycol are some of the Sustain and Blink products. The glycerin-based ones, those are the Soothe and some of the Refresh. And then there are some other ones that have other kind of active agents. And the variables beyond the active agent is viscosity. And especially when you're trying to flush out antigens, the low viscosity are probably better. The preservatives, again, just not to add more complexity to the situation. In allergic conjunctivitis, we often recommend the preservative-free. And then the temperature, sometimes in allergic conjunctivitis, Cooling the lubricating drops before using them makes the patients feel better. And it's important to recognize that beyond the lubricating active agent, there are additives. And some of the new ones that are coming along that are going to be over the counter are going to have anti-allergy components. And so again, there's so many different types of lubricating drops, and there's no data on which is best for allergic conjunctivitis. But because the idea is to flush away the allergens and not to create more problems, low viscosity, no preservatives, and maybe cool them. And studies have shown that they do help. One of the studies looked at grass pollen as the exposure and looked at the outcome of using lubricating drops, cold compresses, both or neither. And the outcomes were conjunctival hyperemia and symptoms, and both were improved when you perform these non-pharmacological treatments compared to doing nothing. And the combo was slightly better than just the lubricating drops alone. So it is important to remember that there are options out there that are non-pharmacological, and I think patients should really be told about all their options. So people have looked at lots of different lubricating eye drops. And again, there are a lot out there. And the general punchline is that with different lubricating drops, they all had some effect on allergic conjunctivitis. So let's go back to our patient, our groomer, who may be triggered by her dog cleaning supplies. What do I recommend? Well, I don't want her to quit her job, but I want her to try to avoid contact with the chemicals to her eye as best as she can. So goggles at work, avoid touching the eye, lots of hand washing. And again, my go-to is an antihistamine mast cell stabilizer. I do talk to my patients about the different over-the-counter options, but ultimately I let them choose the one they prefer. So we talked a little bit about SAC. That's the one that's generally seasonal and generally driven by environmental problems. PAC is more perennial because it's driven by things that are encountered all year round, things like dust and animal dander. And it's generally milder, but more persistent than SAC. And the inflammation, everything you see is typically lower grade. So those are the things that differentiate them, but there are a lot of similarities, like the pathophysiology, which is again mast cell driven and is a type 1 IgE hypersensitivity. But where PAC diverges is the chronicity. And so there are different immune signatures because ideally, if you don't live in Miami and have chronic exposure to pollen, SAC resolves and it gives the immune system time to reset. But with PAC, with constant exposure, you have certain types of cells, Th2 cells, NK cells that go up, and other types of cells, regulatory T cells that go down. And the cytokine findings are different in terms of the pro-inflammatory cytokines that are found. But the reason I lump them together is despite the nuances, the treatment is really similar. But the punchline is we started this by really highlighting that not all allergy is the same. And I think the next two that we need to talk about are VKC and AKC. That stands for vernal keratoconjunctivitis and atopic keratoconjunctivitis, because those are the ones that are visually threatening. And our goal is to protect vision. So let's start with VKC. It's slightly different from SAC and PAC in that these are generally young males, and environment makes a huge difference, hot, dry, and rural environments. And it always amazes me when I look at a map of VKC around the world. I'm here in Florida. I hardly see VKC, and my colleagues in India see so much of it, also in Africa. And so again, it just shows you that there are environmental contributors to VKC distribution. And the punchline is really pollution of all types, dust, wind, sunlight. That seems to be more important than a specific allergen like pollen. And in fact, some patients who have VKC, when you do allergy testing, they have no demonstrable allergic reaction to any one of the testable agents, but they look like they have an allergic conjunctivitis. So it's more like allergy to everything that they are that their eyes come in contact with. And so there's always a question of why are boys more susceptible to VKC than girls? And oftentimes the concept of are hormonal factors driving it? And maybe that's why this tends to resolve by puberty, because they just kind of sort themselves out, but it's still not fully understood. Now, some things are shared between VKC and SAC in terms of this generally because it's driven by various environmental factors. There's generally a season, again, different season in different areas of the world, but generally driven in spring. So it's predictable, but it is perennial in some people. And the risk factors are shared in that many of these patients have evidence of allergy in other compartments, rhinitis, dermatitis. The pathophysiology also has some things that are shared and some things that are different. There's a type 1 IgE mediated response, but also a type 4 non-IgE mediated response. And that becomes important when we come to treatment. So with type 1, we already talked about it, same as SAC and PAC, you're dealing with degranulation of mast cells. But where does VKC differ? It differs with the non-IgE component. And it's the CD4 Th2 lymphocytes are predominant in VKC. And so what we think happens is you have these non-specific environmental triggers, and they activate something called TSLP. And that causes these dendritic cells to express things that prime T cells. And these T cells then become Th2 cells. And in this case, eosinophils also come in and are really the bad guys because they are responsible for the sight-threatening complications of VKC. And activated eosinophils release lots of things, but inflammatory proteins that lead to the things that we really worry about as ophthalmologists, shield ulcers and persistent epithelial defects. And similar to SAC and PAC, it is a little bit of a cycle of inflammation where these proteins then stimulate further mast cell pathology and it becomes a cycle of inflammation. One of the biggest differentiators is VKC is what we see on exam, which are these giant papillae. That's the hallmark structural change, and it's mostly the upper eyelid in the palpebral conjunctiva of the upper eyelid. And one of the cytokines that drives this is IL-4, and it triggers these growth factors that then cause tissue hypertrophy. Another finding that is also involved is neurogenic inflammation, where the sensitized nerves release substance P and NGF, and that causes more mast cell degranulation. So you can see, unlike SAC and PAC, where it's still a lot of inflammation, but more one arm of the immune system, here there are so many different players and tissues involved in leading to what we see in VKC, which is these giant papilla under the upper eyelids. And the reason that we are really scared about this is because these are young patients, and those giant papilla release cytokines that can cause what we refer to as shield ulcer. So an ulcer is an epithelial defect with stromal loss. And in this case, the picture you're seeing, it's not an infective ulcer, it is an inflammatory ulcer. All of the mediators I just talked about, they cause the breakdown of the epithelium and then the breakdown of the stroma. And when this happens, you're at risk for corneal scarring. And so the goal is to attack the inflammation and break the cycle so that this doesn't happen. And the way we do this is by hitting the inflammation hard. Here, it's topical steroids, sometimes interlesional corticosteroids into the tarsal plate, sometimes surgical removal of the large papilla if you can't get a handle in the situation. This is obviously reserved for the more severe types. But more than treating the inflammation, because it's predictable, is preempting the inflammation. And because there is a component of a type 1 IgE hypersensitivity, we recommend starting antihistamine mast cell stabilizers a month before the season and continuing them throughout the season. But this is a time when mast cell stabilizers alone may be helpful in kids, and this is the situation where mast cell stabilizers alone can be used. But there are other potentially anti-inflammatory agents that we use because it's not just about IgE associated inflammation, and there also is a T cell process that we're trying to modulate. And we have lots of T cell modulators in the form of topical therapy, both cyclosporin and tacrolimus. And there is a cyclosporin 0.1% that is specifically approved for VKC and AKC. A bigger question is when we should consider systemic therapies in these kids. And the bottom line is we just don't know. There's no great data, but there have been case reports on oral agents used in VKC, although we need more data. The biggest thing to know is to understand that the course is pretty predictable in that it usually presents before age 10. It's usual seasonal, but fortunately, most kids resolve this process around puberty. So I always tell the kids that I have, you just need to make it to puberty. Having said that, that's not everyone, and there are some people that their VKC evolves into an adult form of allergy. So let's get back to our original patient. Hopefully you remember him. He was the one who has these funny skin changes. And I showed you that he has skin rashes everywhere and has been diagnosed with atopic dermatitis. And so in this case, this helps us narrow down the differential and identify his allergy type as atopic keratoconjunctivitis. And here's another case of one of my AKC patients. He's someone who has had symptoms for a year, itchiness, irritation, and he has tried a combination of antihistamine, mast cell stabilizers, along with lubricating drops, everything we just talked about for SAC and PAC, and none of these are really helping. The one thing that does help is his vasoconstrictor, but again, we're trying to avoid chronic vasoconstrictor use, and he's just really unhappy with his course. And when we look at his palpebral conjunctiva, we see something that I haven't shown you before. You can see that you can't really see the blood vessels, but you also really can't see papillae. The whole thing seems to be covered by something gelatinous. This is an example of papillae, and you can clearly see them. So what's going on? So what are we missing in this patient? Well, it's like there's like agar on top of his conjunctiva, and sometimes you see the same picture on top of the bulbar conjunctiva. And here are all different examples of this. And this is a clue, along with some other clues that we'll talk about, that we're dealing with AKC. So how do we diagnose AKC? Well, it starts by looking at the skin, because AKC is in 95% of patients with AKC, they also have a diagnosis of atopic dermatitis, which means you see skin changes. And these skin changes are consistent. You see thickened skin. You see a cicatricial ectropion, so the eyelid is being pulled away. You see hyperpigmentation and flakiness. You see it on the forehead and the periocular skin, on the eyelids. And you see these changes from across the room. So I always tell my residents the exam starts from across the room because you can't see the skin changes when you're already at the slit lamp. But it is important to look at the ocular surface. And one of the many things you're seeing is these gelatinous changes. Those are clues that you're dealing with AKC, along with what we already talked about, papillary conjunctivitis, bulbar hyperemia. But some things that you see in these cases, again, that are why they get vision loss is you see very prominent scarring. You also see epithelial disruption. And the problem is when many people see epithelial disruption, they get diagnosed with dry eye. But it's important to recognize that seeing epithelial disruption does not mean it's dry eye. Many of these patients will tell you that their eyes feel dry and you see epithelial disruption, but they do not have dry eye. And it's because, again, people with atopy, it's the opposite. They're actually making a lot of tears. So if you put the Schirmer strips in, they'll soak them within a minute. And so it's important to understand that your eyes can feel dry without being dry, and you often see signs of what we traditionally call dry eye with atopy, but it's different. So what are the risk factors? The biggest risk factor of AKC is having atopic dermatitis. And the way I look at it, AKC really is a skin disease. And all the other atopic comorbidities we also talked about, probably driven by genetics. And just like VKC, you have to take AKC very seriously because it can lead to vision loss. And so I showed you this picture before. It can lead to cicatricial conjunctivitis. And when you have a cicatricial conjunctivitis, that can lead to limbal stem cell deficiency, a cause of vision loss. You can also get weird infections. This is one of my atopic patients. They had Citrobacter infection, which is not a common infection in the eye. You can get herpes. You're more susceptible to herpes. It could be bilateral, multifocal. And these are the patients where instead of healing normally, like a dendrite often does, it heals with scarring because these patients are more likely to scar. Some other associations that can lead to vision loss, keratoconus, cataract, and again, we talked about herpes. Another thing that you have to worry about atopes because their immune system isn't normal is they're more susceptible to OSSN or squamous cell cancer of the eye. And this is one of my colleagues' patients who had an exenteration due to invasive squamous cell in one eye and now has a OSSN in the other eye that's being treated. And looking at his skin, you see all the features of atopy, flakiness, and an ectropion because there is a cicatricial ectropion pulling his eyelid down. And so the question is, why didn't our patient get better with a antihistamine mast cell stabilizer? It works for SAC, it works for PAC, it works for VKC, but it doesn't work for AKC. So again, what we need to remember is that AKC is really an extension of the skin. It's an atopic dermatitis, and we need to understand how to treat atopic dermatitis in order to treat AKC. So who are the patients that get AKC? Unlike VKC, they're older, but there's still a male predominance. But here there's not a geographical predominance like we saw with VKC. And generally, AKC tends to be chronic. And it's important to differentiate AKC because the treatment is different. So how can we differentiate? We talked about how it's all about the skin. Have to make the diagnosis across the room looking for the various features that are common in atopic dermatitis. And unlike SAC, PAC, and VKC, AKC has its own pathophysiology that really starts as a skin disease. The problem really is genetic predisposition and epithelial barrier disruption. And many studies have shown that it's a filaggrin mutation that causes tight junction dysfunction. And that barrier disruption allows lots of things to happen, but mostly that all of these allergens and microbes and irritants from the outside world now gain access to these subepithelial immune cells. And like all allergic processes, there is an IgE-mediated mast cell activation that drives this, but there's so much more. So here, the T cells, again, are really involved, but unlike VKC, which is mostly Th2, this is a Th2, Th1 T cell response, which really drives home chronicity. And in addition to the T cells, there's this constant interaction with the outside world where these patients are more susceptible to staph and staph superantigen amplification. And so if you swab patients with atopic dermatitis, they're more frequently colonized with staph. And we think that the enterotoxins that staph makes are actually driving some of the T cell activation that drives the disease process. And again, unlike all the other allergic subtypes, you get tissue remodeling, and you get a little bit of that in VKC with the giant papillae, but here you're really getting scar formation, which can lead to permanent vision loss if you get limbal stem cell deficiency. So to me, of all the allergy subtypes, AKC is the one I am most worried about because it is a web of inflammation involving all arms of the immune system. And if you look at it, there haven't been as many publications on AKC than atopic dermatitis. So we really look to the atopic dermatitis literature to help us understand how to manage AKC. And so the principles are really patient education, allergen avoidance, treating secondary skin infections, and targeting the barrier disruption, mostly with ointments. Using topical corticosteroids when you need them in the lowest potency you can for the shortest duration you can because steroids have side effects. But the biggest punchline in AKC, unlike SAC and VKC, is that it is a chronic disease and it needs chronic therapy. And so here, steroid-sparing therapy is so important. And because of the importance of T cells and the pathophysiology, this is when I grab my T cell modulators like tacrolimus, which I love, identified from the soil at the base of a mountain. And in atopic dermatitis, there is good evidence when there's mild dermatitis for topical tacrolimus ointment. And the oral tacrolimus is really reserved for more moderate and severe cases. So knowing what we know about atopic dermatitis, can we apply these principles to AKC? And so the general treatment is to, again, flush out the allergens with lubricating drops, to avoid the allergens, to avoid chronic topical steroids, to try to reduce staph load, maybe with something like eyelid hygiene, to go for cold compresses and avoid rubbing the eye, but really to go for T cell inhibition. And we have a lot of different ways to approach that. We have topical cyclosporins in various concentrations that are available. We have topical tacrolimus that can be made into an eye drop, but I really prefer ointment around the eyes because the topical tacrolimus eye drop can have side effects like burning. And so that's what I did in our patient. We started topical cyclosporin and topical tacrolimus ointment around the eyes, and he did get better, but his skin is still very itchy, not only around his eyes. And that is because AKC, it's really a skin disease, and atopic dermatitis distribution can be periocular or it could be anywhere else. And so for these patients, I do consider oral medications with appropriate monitoring. And this is just one example of my patients who had really, really severe AKC and atopic dermatitis. And he had been off and on steroids his entire life. And we started oral tacrolimus with really remarkable results. And you can see his skin and his eyelids look so much better. But these are older cases, and there's an evolving group of therapies for atopic dermatitis. Some of them are topical, some of them are systemic, and we're still trying to understand how we can use them for AKC. And we need more data because, in fact, at least one of them, dupilumab, may make AKC worse. And so there's an entity called dupilumab-associated conjunctivitis, where after about 4 months of treatment, the skin disease can get so much better, but the conjunctivitis can get worse. And the thought process is that maybe we are blocking the Th2 pathway and it shifts towards a more robust Th1 response, but it could be something else. So this is one of my patients. I showed her picture before. She has hyperpigmentation and flakiness. She was diagnosed with dry eye, but she's making plenty of tears. And she really has a papillary conjunctivitis. But when we start talking to her about her papillary conjunctivitis, she reports that she's had atopic dermatitis from an early age. Her IgE levels systemically are through the roof. We looked for organisms that may be driving it because you could see a papillary conjunctivitis in the setting of infection. We couldn't find any, but she told us she was totally fine until she started dupilumab, and her skin findings got so much better. But after about 4 months, that's when she started having the eye findings, and that's when she was diagnosed with dry eye. But in fact, what we think she has is medication-associated papillary conjunctivitis. And because we think it's an inflammatory mechanism for the conjunctivitis, short-term corticosteroids and long-term T cell modulation. And that is my secret sauce, both for AKC and dupilumab-associated conjunctivitis, is to use T cell modulation, both at the level of the eye and around the eye to the periocular skin. And she got better with this treatment, and we were able to continue the systemic treatment because it was helping her overall. And that is the goal. Now, because we have other agents in atopic dermatitis, some of the dermatologists I work with are switching and trying other options to see if you can still get the skin control without the conjunctivitis. But again, we don't know. So here are some of the newer options. There are ones that block specific cytokines like, again, IL-4, IL-13, IL-31. And then there are JAK kinase inhibitors that have some FDA boxed warnings. So they're generally second line, but all of these are used for atopic dermatitis. Since they're relatively recent, we still don't know how they're going to fit in with AKC treatment. But a different question that these patients have really kind of introduced to me are whether my atopes are really canaries in the coal mine. Because our patient whose tears burn his skin, he's really miserable. He says his skin constantly itches, and he says he gets rashes with every shower, and he has to use ascorbic acid to neutralize the chlorine, which he says is the source of his rashes. He also tells me he can smell carbon monoxide. And as we all know, we call that an odorless gas. And that's why he's the one who told me, I think I'm a canary in the coal mine. So the idea is we've already established atopy as a T cell mediated response, but we really haven't talked about a T cell mediated response to what. And the thought process is maybe atops are responding more aggressively to toxins in our environment that are probably bad for all of us. And so over the years, I have started testing a lot of my atopes, not just for environmental allergies like pollen and flowers and trees, but also for chemicals. And I've always been surprised at some of the things that come up, like my patient here who's allergic to formaldehyde and he won't stop smoking. And we know that formaldehyde, many things is a byproduct of smoke. Here's one of my patients who's allergic to preservatives in cosmetics, and she had to stop using the cosmetics she was using in order to help her periocular skin. And then another one of my patients who turned out she was allergic to nickel, which she had in her shower head. And so when she replaced her shower head, her symptoms got better. And so over the years, in my patients who don't respond to kind of my low level topical and periocular T cell modulation, I do send them for patch testing because I've been surprised at what we find and what they can modulate. All right, we're almost at the end, but there are a few other allergy subtypes, and another one is giant papillary conjunctivitis, or GPC. Ophthalmologists love abbreviations. And here you see upper eyelid large papilla, similar to what you see in VKC, but here it's generally in older individuals in the setting of contact lens wear. And while you could see it in any contact lens, soft contact lenses are more associated than hard, non-disposable, more than disposable. And it's really about the antigen contact time with the surface. So prolonged wear time, poor lens hygiene, high water content, all of those are really risk factors to let whatever antigen people are responding to contact their surface. But there are also other risk factors like using an allergenic contact lens solution or just a systemic predisposition to having atopy. And here, there are some differences along with the type 1 hypersensitivity that keeps on coming up. We think it's actually a mechanical issue where you get tissue injury and barrier disruption, and you have these mechanoreceptors activating and causing an inflammatory response. But when you look at the histology, there are certainly similarities to VKC and also in the clinical picture. And so the key to making the diagnosis in any contact lens wearer that has any symptoms, and also it's a good idea in a contact lens wearer that doesn't have symptoms, is to flip the upper lid and look for giant papillae, because that's how you make the diagnosis. And sometimes the treatment is easy. You just tell them to stop wearing their contact lenses, but sometimes they need contact lenses. So it's important to try to improve their contact lens hygiene and try to find a contact lens routine that will not give them a response. When it's moderate, I do use topical therapies, and these are similar to the ones we've heard about because there is a type 1 hypersensitivity, a combination, antihistamine mast cell stabilizers, and short-term steroids if there's a lot of inflammation. But it is important to recognize there are other causes of allergic conjunctivitis that may not show up with a papillary conjunctivitis. And in fact, sometimes they show up with a follicular conjunctivitis. And the offending agent is often topical medication, oftentimes in the form of glaucoma drops, and oftentimes it's bromonidine. So here it's slightly different because this is not type 1 hypersensitivity. It's a type 4 T cell mediated process. And while there is a median duration of 32 weeks, it can show up earlier or later, sometimes years after using a glaucoma treatment. And the way you treat this is you stop the offending agent. But sometimes it's not so easy. This is one of my patients who has follicles more so in the right upper lid, and he only uses glaucoma drops on his right side. So this is his left side is normal for him. Um, and he is on 4 different types of eye drops. So which one's the offending agent? Well, we stop the bromonidine because that's the one that generally is the cause of the allergy. And you can see slightly less hyperemia, but you can see that there are follicles still present in the upper eyelid, and now there are new follicles in the lower eyelid. So maybe it's not the bromonidine. Let's stop another one because I don't want to see allergic conjunctivitis, but he has advanced glaucoma with 2 tubes. And so it's a little bit of a balancing act of trying to address the allergy, but addressing the glaucoma as well. And in his case, we stopped the Netrosudil or Repressa, and we're hoping for the best. So what are the take-home points on allergic conjunctivitis? The biggest thing to remember is it's not one disease. There are different types of allergic conjunctivitis. They have different underlying risk factors, different presentations, and they need different treatments. But it's really important to identify the ones that are visually threatening and to address them so that our patients don't lose vision. It's important to know which ones have a predictable time course so you could preempt treatment, and which ones are chronic and need chronic treatment. In all cases, it's important to avoid chronic corticosteroids when you can, and to then target with non-steroidal options that target the appropriate pathophysiology. But it's also important to understand what are the triggers in the environment, which may be different in the different allergic subtypes, and to target those as well. So thank you so much for joining me on this journey to understand how interesting and complex allergic conjunctivitis can be. And hopefully this can help you identify and manage these patients a little better. Thank you.